Hey, welcome to it's January. It's January. January's
It
panel
is.
discussion from Inspire Respiratory Critical Care. Um, my name's Keith. I am the host of the panel discussion and the moderator. And these are my colleagues and board members from Inspire Respiratory Critical Care. Go ahead. My name's Keith. I practice in Charlottesville, Virginia. I'm a respiratory therapist. Thomas, you want to introduce yourself?
Yeah, I'm a respiratory therapist from Ontario, Canada.
Andy?
Afternoon, everyone. My name is Andy Klein. I'm a respiratory therapist and educator from Chicago, Illinois.
And Troy?
Yep. Respiratory therapist in Columbia, Missouri.
So we're doing something a little different this month, and kind of putting everything out there on the line. We decided instead of focusing on a specific topic that we would ask participants to bring us your questions about respiratory critical care. And so if you have them, then go ahead and put them in the chat and we will go ahead and get started. As a reminder, once this panel discussion concludes, we're videotaping it. And so we will post it on our YouTube channel. And, there's Thomas's dog right on time. And we'll post this panel discussion on our YouTube channel and post it on LinkedIn, and you should be able to get it and share it and go ahead and just use it for whatever you want to use it for. So
my dog tried to ask the first question, but she doesn't speak English. So
what was that? Yeah.
Somebody's walking by the house. She needs to protect me. Well, not somebody. It's if a dog. I can tell when somebody's walking their dog because my dog loses their mind.
Yeah, I got one like that too. He's in that. You can probably see him in the mudroom back there behind me. All right. So anybody have any questions that are participating? Thomas, can you tell how many people are on the call right now?
Yeah, there's 9 people so far.
Okay.
I think we had 40-something registrants for this one.
Yeah.
I actually know a couple of these. One's a former student and one is one of my coworkers there.
Great. Well, they have the opportunity to ask us any question, get us started, ask something, or just say, hey, talk about this, please.
Peter, Steph, you guys want to start us off? Or anybody else?
Danielle Hardy's out there. She's always got a lot to say.
PRVC. You want to talk about? So I'll tell you a little story. I just came back from Saudi Arabia. I was there and presented, and the majority of the people in the audience, that is their standard mode of ventilation for patients, and that. And that's not crazy. It's not uncommon. The last hospital I worked at, that was also their main mode of ventilation. And after I gave a presentation about ventilator modes, I had some words to say about PRVC. And the bottom line was I wasn't criticizing the use of it so much as you need to understand what the mode is doing and understand the limitations of the mode. Simply put, if a patient has an intact respiratory drive and they get even 10 mils more than what the ventilator is targeting, the machine will ramp down the pressure. And the minute it turns down the pressure, the patient usually responds with increasing effort. And therefore, you end up with this vicious cycle where the lower the machine ramps down the pressure, the higher the patient's respiratory drive is. And then often what can happen, because most ventilators will go down to 3 centimeters of water above PEEP, you will end up with a low pressure alarm going off. And if you don't get there quick enough, sometimes nursing colleagues may sedate your patient. And this is unfortunate situation to have, because then you prolong mechanical ventilation simply by that logic. So that's a little bit about PRVC. If the patient's passive, it doesn't. If the patient's passive, whatever, you're guaranteeing minute ventilation. It's very similar to volume assist control. But with volume assist control, which I like using as a passive mode simply because I can institute a short pause, use faster flows, get real-time driving pressure. But the minute my patient is active, I don't want them on a mode that targets or controls volume. I want them to be able to, I want to see what they want to do, and I want them on a pressure targeted mode. And you might argue, well, PRVC is a pressure targeted mode. It is, but it constantly reduces pressure if the patient inspires more than the volume you've set. So
I would just add, Thomas, that I agree 100% with you in that it's really important to understand how the mode works. And I can tell you that that I've had conversations with bedside RTs that may not have a lot of experience or may have a lot of experience but aren't super engaged, et cetera, et cetera. And I always ask them, how do you think this, what do you think the advantage of this ventilator mode is in this particular patient? What, and how does it perform in a way that you think it's advantageous for this patient? And I've heard such a wide variety of explanations. I've heard that, well, if the patient wants more support, the ventilator gives them more support, et cetera, et cetera. It's pressure targeted, so it's safe. So you control the transpulmonary pressure in it, blah, blah, blah. So all of that's false. It's exceedingly important to understand any mode of ventilation that you're using. Volume targeted ventilation like PRVC, VC plus, I can't remember what it's called on the ventilator that I actually use, the G5, but it's got its own version, APV or something like that. None of it makes any sense to me in terms of the acronyms, et cetera. Yeah, APV. Thanks, Danielle, and Andy shaking his head. So, if you look at the average ICU patient, the average ICU patient has some level of pain. They have some level of anxiety. They have some level of metabolic disarray. They have they may be febrile. There's so many reasons why the average ICU patient may have an unusual or increased drive to breathe, right? And so acute compliance changes like pneumothorax, alveolar edema, other pleural diseases, just a myriad of different things that change a patient's compliance and changes their drive to breathe, that I'm really uncomfortable using a mode of ventilation that will decrease the support when a patient needs it the most, right? Yeah. So a patient has as an example, how many patients in the ICU have metabolic acidemia? Most of them, if you look at it, or at least a large portion of them do. And if somebody has a metabolic acidemia and they're neurologically intact, even if they're partially neurologically intact, they increase their drive to breathe. If you're targeting what you think is a safe tidal volume, which we all do, we all have gotten into this sort of, even our EMR system tells us this is 6 milliliters per kilogram predicted body weight for your patient. And it always seems low to me. And if I'm trying to target that tidal volume and a patient needs more support, they're going to outstrip that tidal volume that you have dialed in to target. And like Thomas explained, is going to incrementally decrease your support. So you wind up having sickest patient in the ICU on the least amount of ventilator support. None of that makes sense to me. Conversely, if a patient has a decrease in compliance, the patient's going to have a harder time getting the tidal volume that you have targeted. And so the driving pressure or the pressure support is going to go up. And it may go up more than you're willing to let it go up.
Yeah. So let me, if you want, Keith, I'll demo it right now. This is a simulation here. This is a patient with a respiratory drive, the P0.1, 2.5. Okay, so they have respiratory drive. If I increase the respiratory drive, and let's just pay attention, the PIP is 14. PEEP is 5, so they're getting about 9 centimeters of water of delta pressure. Okay, so that's the pressure control level they're essentially getting now. If I increase this patient's drive, let's say it gets elevated. Let's say they've woken up, they're triggering now, but they have an elevated drive. As soon as the patient pulls in more volume than they're supposed to, the machine will start ramping down. You can see the pressure just dropped here, and pressure dropped again because the patient's pulling in 600 mils. And this ventilator will go down. I've programmed this to only go down to 3 centimeters of water above PEEP. So essentially, and you can see the if you look at the flow here, it's completely rounded. The patient is doing all of the work here. The ventilator is not doing anything here. So this is what can happen the minute your patient has a significant drive or a high drive. It will outstrip the ventilator. So you walk up, the patient looks horrible, and you think, oh, well, I'm on pressure control and variable flow. Sure, the patient's getting the flow that they want, but they're not getting any assistance from the ventilator, like 3 centimeters of water. So you have to ask yourself, if you look at your patient, think to yourself, would I put this patient on a pressure support of 3 centimeters of water? And if that sounds crazy to you, that's what essentially you're doing. So what can you do in this situation? Well, you can try increasing the tidal volume to a safe limit. So if you're delivering 6 mils per kilo, try 8 mils per kilo, or you can simply switch them to a pressure targeted mode and see what kind of tidal volume you want, but something more than 3 centimeters of water, and see if it reduces their drive to breathe.
Tom, can you tell us a little bit about what you just showed us, that app that program that you developed, and talk a little bit about
sure. Yeah, it's a free simulator. You can go to sim.rtmaven.com, or you can go to rtmaven.com, which is my calculator. Hold on, let me share my screen again. I realized I got rid of it. So I have a calculator called rtmaven.com, and there's a link right here that goes to the simulator. However, the simulator, you can just go directly to it. It's sim.rtmaven.com. It defaults to volume assist control. This is the tab I was on here. This is the PRVC. So yeah. And there's a few modes. There's pressure control, volume control, PRVC, pressure support, and PAV. Which I realize I don't think I put the PAV tag up here, did I? Is there a tag there for PAV? No, I didn't. I need to add that. All right.
And something else, Thomas, that you mentioned was if you're not there to see this, and it's likely that if you're a busy RT in an ICU, you won't be there to see that.
Yeah.
The nurse is going to turn the propofol up, or they're going to turn the midazolam up. And
yeah, the hospital that I worked at that used this as the standard mode, this happened to me at least 3 times a month, where I'd get called, I'd get paged because of a low pressure alarm. By the time I got to the room, I'd get there, pressures look fine. The nurse is like, they looked horrible. I increased the sedation, or I gave them a bolus of sedation. And my first response would be like, can you turn it down? Again, if it was a bolus, I can't do anything. But if they turned it up, I'd be like, can you turn it back down? I'll stand I'll stand right here and wait for them to wake up so that I can properly titrate their ventilation.
Yeah.
Looks like they're sucking a tennis ball through a garden hose.
Exactly.
I sent you some pics, Tom, on your email. I don't know if you can show them, but they're live pics of
let me download
It's not the greatest picture because it was taken with a camera at an odd time, but this is one of those patients that looked like they were sucking a tennis ball through a garden hose.
Yeah, let me get it here. It's uploading now. 1 second.
But you're exactly right. You just need to know the nuances of the modes you're using and the limitations of them. That's for sure.
Yeah. And I really believe that if the standard RT understood how this mode works and how it responds to an increase in need for support, that they probably wouldn't just empirically use it on everybody. So anyway, that's why we do these kinds of things, right? And thanks for sharing the simulator again. Okay, you're going to show.
Yeah.
Pictures.
So this looks like. Yeah, go ahead, Troy. This is your thing.
Well, I mean, the first thing you notice, this was in our acute care surgery area. They called me up there to troubleshoot the ventilator. There wasn't a lot of troubleshooting to do. You can see the mode was PRVC. They have the PEEP at 16, the tidal volume set at 420. If you look at the expired tidal volume on the bottom right there, so they're exceeding it consistently. So what the ventilator is doing is just slowly decreasing the amount of pressure to try to get back to that tidal volume that you have set. And you see the
Yeah,
peak
and there's some
pressure
early,
there.
you can see early
Yeah.
cycling as well when the ventilator cycles off. There's
Yeah.
blunting of the peak expiratory flow.
And
So the eye time's
rounding
not
of
long
the
enough for their drive.
flow
Yeah.
scalar. Yeah. And the peak
Yeah.
pressure at 21. So you're only
Yep.
getting what, about 5 centimeters of support. It's another
Yeah, there's
kind of
a
poor
there's
shot.
a zoom out, but yeah.
And then after we
Just put them
switch,
on pressure control, and then this is
Yeah.
just switching them to pressure support, right? Yeah.
so they really just wanted just a tad bit higher tidal volume.
Yeah.
You know, not even that much more, but yeah, that kind of just freed things up a little bit, and that was all within a few minutes of just walking in the room. So
Yeah. Sounds good. Put the
Yeah, Thomas,
simulator
can you
in the
put the
chat. Sure.
simulator?
Yeah.
And
I'm
let's
on
go
it.
ahead. And I think it's safe to say that all of our panelists that are here present feel about the same way or understand that, you know, the nuances of PRVC. And I personally don't ever use it in my practice. And so I think it's safe to say that we all don't necessarily use it as a primary mode.
Mm-hmm. Now, the second question that got asked that I just going to throw this up there quickly because I was actually surprised. The RT department in this hospital has just started assisting with bronchoscopies. I mean, I've been assisting with bronchoscopies since I graduated over 20 years ago. I was actually surprised that this wasn't already a practice in their hospital. So RTs in every hospital I've worked at are at every single bronchoscopy to assist. Although it's in our scope to actually perform a bronchoscopy, we're typically there assisting at least in the roles that I've been in my hospiters that I've worked at.
Let's go around the room and respond to each of these questions if we can.
Sure.
I'll go ahead and everywhere I've been, we've always assisted in bronchoscopies. Where I trained, once we started to do EMBs and EBUS in the labs, we started to assist with those. We assist every now and then. We'll drive the bronch. We don't usually do a therapeutic bronchoscopy, but we'll occasionally drive the bronchoscope during a percutaneous trach. Certainly, while performing an intubation, that's a possible approach that we could use. But at the very least, we assist in the bedside bronchoscopies in ICU. How about you guys, Andy?
Yeah, I think everything you said, Keith. We assist in the ICU. We have a diagnostics department that does PFTs and other diagnostic testing, 6-minute walk tests, et cetera. And they also control the bronch suite. So one of that staff every day is assigned to be basically the right hand of the bronchoscopist that day. And then whoever's in the ICU that is performing the bronchoscopy would then just assist and, forward their phone if it's going to be a long procedure. But most of the stuff you talked about, the EBUS and all that stuff, they have to go to the bronch suite for. We don't do those things at the bedside. We would just do the basic, identification, percutaneous tracheostomy, as you mentioned, the easy clean outs and those types of things. And as you mentioned, there's been one place I've worked, and it was a smaller hospital, and they brought a procedural nurse and some other techs with them, and they would just travel with the doctor to every bedside. So it's the only place I've seen or really talked to anyone about where we didn't have an active role in assisting with bronchoscopy. And it was nice from a workflow standpoint to have someone else just come in and do it, and you could continue to see the rest of your patients, but now working at a place where we are front and center with assisting with bronchoscopies, I think it's the right thing to do. And I think there's been just countless occasions where the RT was able to intervene when the patient was decompensating and things like that, which wouldn't happen if they weren't in the room assisting. So.
Right. Troy, how about you guys?
Staff.
Oh, your microphone's kind of cutting out there, Troy.
What's that?
Okay.
There you
Your
go.
microphone's kind of cutting out.
Better? Better?
Yeah, you got to get the same.
Oh, yeah.
With your mic.
Yep.
RP, like Andy, RPFT and bronch suite are connected. So they the staff there go back and forth between the two. We do EBIS at the bedside in the ICU sometimes. If that's the case, then one of the bronch suite respiratory therapists will come up usually. But the routine ones we usually help with. We use the glide scope and the ambu, and most of the RTs will just pitch in and help the team get through the bronchoscopy when one comes up, which is fairly frequently.
So Cynthia also asked, what is our role in the OR? I'm not sure if you're connecting that with the bronchoscopy, but in the operating room for us, sometimes we'll go to the operating room with the ICU ventilator and keep them on if they're super sick and unstable, and you don't think that they would tolerate coming off the ICU ventilator and going on an anesthesia machine, then we'll go sit with the patient in the operating room sometimes.
Do y'all have anesthesia assistants in the U.S., or is that just a Canadian thing?
I don't think that we do. If we do, I'm on
we have anesthesia assistants in the operating room here in Canada. So they're mostly, although you can take anesthesia assistant program as a nurse, I would probably argue that I think 98% or more are respiratory therapists. And generally they actually will assist with things like they can sort of take over when anesthesia wants a break, for example, so they can maintain patients within a medical directive, but they'll insert the ART line pre-op. Oftentimes they may assist with induction, and like I said, for some nerve blocks, they're actually trained to do some of the nerve blocks, so they actually do some of the roles that anesthesia would traditionally do, but are considered safe for another healthcare provider to do it. So we have a different role in our system.
Sweet respiratory therapists travel to the OR when they have a procedure there.
Yeah, I can answer this one easily also with my simulator.
Yeah. So why is this? Why has this happened, Thomas?
Yeah. So in pressure control, if you do an inspiratory pause and your plateau goes up, this is simply the fact that your patient is likely breathing spontaneously. If it goes up and they're not breathing spontaneously, I'd be shocked, because generally what you're capturing is the elastic recoil, the elastance of the patient's effort, essentially. So it's the true elastic property, the elastic stretch. So it's the true driving pressure. This is the same in pressure support. In pressure control, I'm going to show you. This will be a lot easier for me to do it here. So on the simulator, I have pressure control here. I did a pause here, but I'll show you. So I'm going to show you what the patient's effort looks like. So this is PMUS. This is a patient inspiring. And at the end of the breath, they have this, obviously you inspire, and then this is them passively exhaling. It's just the elastic recoil of their effort, right? So they're moving their chest wall. That includes your diaphragm. And then when they relax, that chest wall pressure is coming down. And if you were to perform an inspiratory pause, what happens is that elastic recoil pressure is now generated. You can see as it comes up, the ventilator pauses, and this is the recoil of that effort. So the difference between this plateau and this peak pressure essentially is called PMI, the pressure muscle index. It's not PMUS, but it's similar in nature, that the higher your PMUS is, the higher this level would be. But what this really tells you is that this is the true driving pressure the patient is feeling at the alveolar level. It's not your pressure controls. This is a pressure control of 12. But if I did this maneuver and my pressure is 26 minus a PEEP of 5, then the driving pressure there is 11 centimeters of water rather than, 12. Bleh, can't speak right now. Let me get back to normal pressures here. Okay, so I have a peak pressure of 17 with a PEEP of 5. That's a pressure control of 12. But actually the pressure up here of 26 means it's 21 is the driving pressure. My math was not mathing. Sorry. I need more coffee. I came back from Saudi Arabia 2 days ago, and I don't know what day or time it is. So that's why you can sometimes see it. Now, let me show you a patient with weaker effort. Again, that's a patient with really high, strong effort. And let me just shorten the PMUS duration to something like this. Let's say this is somebody waking up with like weak drive and weak effort. And I'm going to confirm, and then we're going to see what's happening with the PMUS here. Notice how the patient is done inspiring here, right? So this is like a classic patient's just starting to trigger, but there's a little bit of delayed cycling. You can actually see the flow direction change. This tells you your patient's completely passive. And if I were to do an inspiratory hold here, I'm not going to get the same response because the lungs, they've already exhaled while the breath was happening. So this is a typical pause where the plateau pressure may go down. And again, your plateau pressure will be lower than your peak when your flow does not reach zero. If I increase my eye time to something excessively long where the flow reaches mostly zero, then my plateau pressure will essentially be the same as my peak or very close. So you can see my flow is getting closer to zero. So the closer your flow gets to zero, the less of a drop in pressure you're going to have when you do a plateau pressure. But when it goes up, it's because you're capturing the elastic recoil of patient effort.
I think that point is worth reiterating, Tom, because there's a lot of people that assume if you're in pressure ventilation, your peak pressure is your plateau pressure.
Is your plateau. Yep. Yeah, they say I don't need to do a pause because, you know, that's their pressure, but it's extremely important. Let me reset this patient condition here. So this is now a passive patient, but let me just, you know, show you an example. I'm going to do an inspiratory pause here. And you can see my plateau pressure is 15.6. So let's round it to 16. And my peak pressure is 17. So really it's just 1 centimeter of water different. But if I were to have significant resistance, so let me just add COPD to the mix here, then I'm not going to get the same volumes. Notice that my tidal volumes are lower on this same pressure. The reason is that more of this pressure is required to overcome resistance. So if I do an inspiratory hold now, there's going to be a much larger difference between my peak and my plateau because there is significantly more resistance. And you can see my flow is not quite reaching zero, or it's not as close to zero as it used to be. So we have to get out of this idea that the peak pressure in pressure control, simply because it's flat, means it's equal to the plateau. It's not. It all comes down to whether or not your flow is reaching zero. And now that this is rescaled, you can really see that, like this gray dotted line here, it might be hard to see on the screen, but this is zero, but this is clearly not reaching zero here. So of course, when I do an inspiratory pause, it's going to reflect that.
And sometimes even when you do a plateau pressure in pressure control, not only does it continue to go up, but sometimes it never stops going up.
That would be active. Yeah, if the patient's active and fighting against it, it's not going to go up. Right. I'm going to keep it shared, but just pull it off the screen here. There we go. That way I can get it up quicker next time. All right, so moving down the list here, I'd like to know more about event management with ECMO patients. I can tell you practice in Canada at like the largest ECMO center. They just do the 10, 10, and 10, sort of a lung rest scenario. So pressure control of 10, PEEP at 10, respiratory rate of 10. And essentially, as the lungs start to heal, they'll see larger tidal volumes with that pressure control of 10. But that's really the practice that I'm aware of in Canada. It's typical to do 10, 10, and 10. How about you guys? Keith?
Yeah, so that 10, 10, and 10 thing is old. And I'm not saying that people don't still practice that approach, but that certainly, that came from the pediatric data many years ago. What I always say when I talk about managing ventilators on ECMO is that the rules and the rules of mechanical ventilation that we've talked about for 2 years now on these panel discussions almost, and the rules don't change, right? There's the same rules apply to an ECMO patient. They just get easier to follow. And so that's not to say that you wouldn't, 10, 10, and 10 is pretty safe, it seems like, but doesn't mean that you wouldn't customize even further to the patient. But anyway, the rules don't change. You still have to follow all the same rules. They just typically get easier to follow, and if you think about what those rules are, we talk about them all the time: volume, driving pressure, all of the mechanical power. Thomas hates those two words. But all those things we talk about are the same. And if you think about a patient that you may cannulate to put on VV ECMO for respiratory failure, probably has horrible compliance, probably is failing, and you're unable to follow those rules. So that's why you cannulated them and put them on ECMO anyway. And so anyway, that's really all I have to say. That just follow the same rules.
Yeah, and I think to both Tom and Keith's point, I think it's okay to start 10, 10, and 10 and see where you are. And I think the other important factor here is subsequent adjustments, and knowing that most of the adjustments for blood gas management are going to be done with the ECMO pump to the point that you can. That way you don't have to overdrive the ventilator, which you were probably doing if it's VV ECMO before you cannulated them. You're probably either ventilating with unsafe pressures or something unsafe, where you were getting to the limits where you knew you couldn't manage them any further. So, one of the things we quiz our staff on is, all right, you get this just absolute garbage gas after you put them on ECMO and you've got them, tied up with the vent, and they call you to the bedside and say, hey, this gas is horrible. What are you going to do? And the correct answer is, I'm going to talk to the ECMO specialist about, what kinds of changes they plan to make with the ECMO pump, because, if I'm going to change anything with the vent, then we're probably in the weeds. So.
Yeah, the whole idea is essentially not worsening lung injury with a ventilator when you have a machine that's essentially doing gas exchange for you. So the idea is just to minimize any further, ventilator-induced lung injury, right? There's no point in giving the lung rest if you're going to continue to injure it. So it's all about safety at that point. Troy, anything to add?
Relatively low volume.
Oh, your microphone's fluctuating again.
I'm sorry about that. What about now?
Yep.
Better?
Yep.
Okay. We're a relatively new low volume ECMO program. But we usually, with these refractory hypoxemia patients, we prone them. We usually place a balloon. We use EIT, and we leave the balloon and the EIT in place when we cannulate them and use it.
All right. This is a loaded question. There's more than one question in one question. So, okay. I'll do you want to just keep doing this where I'll start and then we just move down it's like the Hollywood.
Yeah, that sounds good.
All right.
I just want to make sure that we get to as many of these as we can, and not
So I'll try to keep this. I'll try to keep this short. Thoughts on current sedation in relation to ventilating patients. So just at the end where it says lean towards more or less sedation, it really becomes patient specific, right? So patient self-inflicted lung injury is still a concept that some people disagree with and some people agree with. There is a current or a recent study that looked at the association between drive and patient outcomes. And in patients who are more hypoxemic, so PF ratio is less than 150, having high drive amplified the negative impacts of driving pressure, for example. And there was also a sort of a Goldilocks zone where it's like extremely low effort and extremely high effort were both associated with poor patient outcomes. Now, what that means is that if your patients are in a nice target zone, then great, keep them in that target zone. The issue we have right now is we don't have any prospective randomized control trials that have looked specifically at, or that have been published yet, that have specifically looked at, if my patient's drive is too high, is it worse to let it rip, or is it worse to control it with sedation and or paralysis or partial neuromuscular blocking agents, whatever? So we don't really know what the safest thing to do is. We do know that diaphragm atrophy is a real thing. It happens very quickly. So we know that sedating and paralyzing patients is not good. But we also have more and more data suggesting that excessively high efforts are also bad. So finding that sweet spot. I do know that certain drugs are better than other drugs at maintaining or decreasing effort versus drive. So, for example, morphine will lower your rate, but won't necessarily decrease your drive. So this is why I often refer to it as morphine breathing. So opioids will make patients breathe less, but they breathe deeper. So they take larger volumes. We've probably all seen a patient on opioids that are just taking huge volumes and you just cannot control it. So whereas propofol, for example, when used properly, can won't reduce drive, but will reduce effort. So depending on your management strategy, that's one way. In terms of asthmatics, until your airways are relaxed, it is extremely, I would say, psychologically painful for a patient with asthma to try and because PEEP as much as we like to try to splint open airways with PEEP, when you have someone who's in active bronchospasm, the PEEP will not open up those airways. So increasing PEEP to try to help them trigger sometimes is kind of not going. It's not going to work, because as you increase PEEP, your total PEEP goes up. In order to help them trigger, you have to be at about 80%, they say, of total PEEP. But when those airways are not opening up, increasing PEEP, you're never going to get to 80% of total PEEP, because you just keep pushing total PEEP up. So until the airways are relaxing and you're able to increase PEEP in a way that doesn't increase total PEEP, so as long as you can decrease the delta, the difference between total PEEP that's measured by an expiratory pause and your set PEEP, when you can start to reduce that, that's when you're going to have the ability for the patient to trigger the ventilator safely. Otherwise, if you had a total PEEP of 12 and a PEEP of 5, and you can't change that delta of 7, in order for the patient to trigger, they have to generate 7 centimeters of water pressure first before they could reach the trigger criteria. So that would be extremely uncomfortable and difficult for a patient to do. So the first step with severe asthma would be to try to manage and control the asthma. And then the minute you can then titrate PEEP to a level that would allow or facilitate easier triggering, that's when you would consider waking the patient up. So it's not some matter of more or less sedation. It's like, could they possibly trigger the ventilator with my ventilator settings or not? And if the answer is it would be very, very difficult, they're not going to like being awake at that point. If my airways are not relaxed yet, please don't wake me up if I have an asthma attack ever. until you've sorted that out, because I don't want to feel like I'm sucking on a straw that's not doing anything. Sorry. So next, Keith, what do you think?
Yeah, I mean, I agree with everything you said. There's certainly some drugs that are better to use with people who have reactive airway disease than others. Ketamine, for example, is probably a better way or a better drug to use on asthmatics. P-Silly, I think I'm a believer in that. I think that we don't know enough about it quite yet to make real dramatic statements, but I think that it makes sense. Some of the very small subsets of patients that have apparently done better on neuromuscular blockade, I think that has something to do with P-Silly. In other words, somebody who's super, super sick, has low compliance, has severe respiratory failure, their drive and their effort can be high, and maybe they contribute to that. Again, we probably, or maybe we, but maybe not we, but I, almost every time we have one of these things, I mention that only about 10% of the ARDS patients that don't survive actually don't survive because of respiratory failure. The other 90% that don't survive are from secondary inflammatory cascades that involve induce multi-system organ failure. And I think that P-Silly is a heavy hitter and a big player in that. So that's really the only thing that I would have to add, other than we know for sure that sedation plays particularly benzos play a big role in delirium, length of stay, outcomes, et cetera. So if you see an opportunity to use lower levels of sedation in a patient, then that's probably what we should be doing. Andy, how about you guys?
Yeah, I mean, I think you guys have hit all the high points. The only thing I would really add to that is I think that it just depends on the, Tom brought up and, really fleshed out the triggering issue. The other thing is obviously the air trapping, right? I mean, if you can minimize the air trapping to enough of a degree and, manipulating your I time, your E time, tidal volume, if necessary, to, deliver a lesser rate if they'll tolerate it. If you can get them to exhale so you don't have this compounding air trapping leading to, hemodynamic compromise, I think you can, not necessarily have to paralyze. I think the sedation to sort of limit their interaction with the vent a little bit is a good idea, but I don't think very, very rarely do you have to paralyze. And usually it's because you just simply don't have the room on your ventilator settings to both ventilate them effectively and give them time to exhale. So I think when you get into that quagmire, you kind of have to take them completely out of the picture.
Troy, anything to add?
I do believe in P-Silly. I think it's right at this point. It's hard to tell exactly how to balance it and what we're looking for when to intervene. Asthmatics generally don't get intubated. When they do, at least my experience, they almost all need to be paralyzed for a short period of time. Most of the time, I mean, in the 80s and 90s, we had asthmatics on ventilators all the time. Rare now. So people think high CO2, turn the rate up. Absolutely the wrong thing to do.
Yeah.
The trigger, like you hit on, is very important. Whether it's flow trigger or pressure trigger, they still have to pull through that gradient, that auto peak gradient, to get to the trigger mechanism. So it's been my experience that most patients with refractory bronchospasm need to be paralyzed in the first 24 to 48 hours.
Yeah, and I think that's key. Like airway or expiratory flow limitation can sometimes be PEEP responsive, but in those patients, like you said, where it's very active and those airways are not they're not going to open with PEEP at all, right? Like that's when the paralysis need, because it would, yeah, like you said, it doesn't matter what trigger sensitivity you're using, they're not going to trigger comfortably.
And I would lean towards less sedation as long as we do it safely and keep in consideration the
we know sedation is bad, right? Just we know that high effort's associated with bad outcomes. So if we can keep them breathing, great. It's just a matter of like, can we control their drive in a way that is not injurious? This one will be a quick one. Troy, you want to start this one so that
I would retire early. That's what I would retire immediately.
What would you do differently?
I'm telling you, I'm not doing it again. I just can't do it. I'm gonna let these young people like Allie do it. Yeah.
You know, I'm not sure, to tell you the truth. I mean, it was sad seeing patients having to say goodbye on a tablet. You know, I think in some cases we kept patients paralyzed too long. We benchmarked our outcomes with other similar institutions in the Midwest, and actually our outcomes were quite good, but it was awful. I mean, I went through the AIDS in the 80s, saw a lot of helpless situations there. H1N1 in the late 2008-9. This was all of those on steroids, and you know, you try to do what you know to do, but you just get so overwhelmed with the volume of patients that you maybe some things get dropped a little bit. It's just it was tough. I don't know what I would do different, to be quite honest with you. I'm not sure I would have anything to say.
Andy? Oh, never mind.
No, go ahead, Andy. I'm sorry.
I was just going to go in reverse order now.
Yeah. No.
Yeah, I mean, I think Troy said it all. I mean, we were a referral center, so we got all the ones from all the area hospitals, and we saw exactly what Troy is describing. And to be honest, as being someone caught in the middle of it, I think as soon as we knew that something would make things better, whether that be event management strategy, whether that be changing the way we proned, whether that be, remdesivir, coming into the picture, whatever it was, I feel like we implemented it the second we knew that it was a positive thing. And I think, I would just try to do that. I would talk to the people on this call, and ask what they're doing and try to pool our collective IQs to, try to bring a positive impact. But at the end of the day, we did what we did because we, at different points along the way, didn't know that much. So we just tried to stick to the rules, right? Good vent management, prone positioning, give the drugs that we think will help, and try to investigate as quick as we can new therapies. And I think that would be the approach again. Even though I think we would probably be in the weeds for a while, like we were with COVID, just trying to figure things out and then, get them implemented as quick as we could.
Keith?
Yeah, I would echo that. And I would say that, we do know a lot more now than we did when we first started getting these patients. And a lot of the good work was done by colleagues of Andy's at Rush. One of the mistakes I'm fairly certain that we made was to inappropriately use high flow. And I think that initially we got scared. We didn't want to use high flow because we thought that was going to increase the opportunity for healthcare providers to get sick with cross-contamination and dispersion. Andy's colleagues did some really good work on that and showed us, and some other people too, and showed us that that's not necessarily true. So I know for a long period of time at the very beginning, we'd used very low flows on high flow that really didn't meet the high flow definition. I think that's an area that we could improve upon. The awake proning, probably we'd start doing that right away when patients started to be, not sick enough to intubate, and so but retire really is my primary thing.
I think, just to expand on your point there, I think that also led to intubating way too many people during the first surge, because we didn't have, or at least didn't think we had, high flow in our tool belt and couldn't manage some of those borderline patients because we didn't think we could, so we just intubated them all.
Yeah, I agree. Yeah.
Having said that, the evidence for late versus early is not overwhelmingly convincing that intubating early was a bad thing. I think the thing I would do, well, it's not that I would do, because I don't write the orders and I don't make the decisions in the ICU. It's the physicians that typically do, but I'll just maybe comment on one of the things I noticed. So initially, many people were worried about high flow, as you mentioned. In the hospitals that I initially worked at, when it first started, we fought that we could use high flow. They tried to ban it, and we argued that we could. But I think the issue that came about later on is that I feel like we completely ignored why we intubated people, like criteria for intubation. Like, there were patients who were on high flow for way too long that should not have continued to be on it. And by the time we intubated them, their lungs were rock hard. So it was the exact opposite. Like, people felt, oh, we were intubating very early at first. But again, when you look at the early versus late, there's no real consensus as to like one was bad. It's just like the outcomes of the patients were not really that different. But I can tell you from a management standpoint, I knew which patients were going to be the hardest to manage, and they were the ones that were on high flow, meaning high levels of FiO2 and high flow, working hard, like clearly, like we're talking rest rates in the 30s, clearly using accessory muscles to breathe, and them just saying, I don't know, they might turn around. Because as soon as you saw one person turn around after 10 days, you felt everyone was going to turn around after 10 days. And I see a lot of you nodding, because I think we all experienced that, where we're just like, this patient has met the criteria that we would have normally intubated. They met it like 4 days ago, and we're still just hoping they're going to turn around. Like, I feel like we just sort of forgot the basics of, respiratory failure and criteria for intubation, because we saw a few people turn around. And I think our own biases got in the way of those decisions. So I would try to advocate more for not letting people stay on a therapy that's clearly failing for too long. I mean, I was calculating ROX indexes, and like, I know it's one score and it doesn't matter, but I'm like, the ROX index is horrible. And look at them. Like, it wasn't like the numbers were just bad. It's like the patient also looked horrible. And they're like, well, let's just give it another day or two. And then that turns into 3-4 days. And then finally they fail and get intubated. And it was.
Yeah. So, I mean, you're absolutely right. And we know from an abundance of experience in this group and in general, that it's a horrible idea to delay definitive support for a patient that needs a specific that needs something. And that's not what I'm not advocating for that. I'm just saying that if you're using high flow at 15 liters a minute because you're afraid that you're going to
that was the biggest thing.
Yeah, that's what I'm trying to say.
Patients coughing, like patients coughing were just coughing were just as risky as someone on high flow. Like, it didn't increase your risk of exposure any more than a patient coughing in a room. So the definitely wasn't.
Yeah, it's interesting which devices cause the most dispersion. And
no, it's surprising.
It wasn't high flow.
No.
All right, let's go.
All right, so this is one. It's funny. This was a hot topic when we were in Saudi last week, because of all the criticism that I was giving on PRVC. We had Emily, who was there, like sort of giving neonatal and pediatric talks. Was funny because she's like, this is like a standard mode in the NICU, and it works, and it's proven to work. And again, I think The issue again comes down to how you utilize it. So in any study, whether let's say it's a neonatal study using something like volume guarantee, they should have a reasonable strategy for example, and also let's face it, like the little ones sort of grow. Like adults, their lungs don't change anymore, right? So like in a neonate, as time goes on, you will likely need to adjust and increase the volume guarantee that you're giving them. In adult patients, it's like we're just setting volumes based on mils per kilo, and those ideal body weight doesn't change, right? The patient is a certain height, they're a certain sex, and that's it. Like that's their given tidal volume in adults. So the success of it in the neonatal ICU is likely a different mechanism. It likely has to do with the protocol. It's likely the volume is likely adjusted. Like they're not going to keep the volume the same on Monday as they will the following week as the baby grows and starts to gain weight. There's going to be a titration algorithm for that. So the success of that mode is likely due to how it's used. Because if you just left the volume on day one and then left it as that, as the neonate would have increased drive and as the lungs started to grow, they would then also strip out the ventilator, right? Like the same PRVC's this or volume guarantee, it's the same mode no matter who it's on. So if you don't adjust your strategy for the fact that their lungs are growing, it wouldn't be successful. So I think the success of that mode in that age range or in that category of patients is likely due to how it's utilized. And in adults, it's just, again, in adults, we can turn the tidal volume up. But what I see is not that. I see people just sedating the patient to keep the 6 mils per kilo. And then that's a whole nother issue, right? Like people just fixating on 6 mils per kilo when patients are trying to recover and regain spontaneous breathing. So I think all of the issues we discussed earlier with PRVC, unless anyone disagrees, I think they're the same issues you need to be aware of, but likely the success of that mode is probably because there's likely a target algorithm based on the growing baby.
Yeah. What little bit I know about babies, that makes sense to me.
Mm-hmm.
We don't have a ton of time left, so let's go with Danielle's next question. I actually have a thought on this, if you don't mind me starting on this one real quick here. So I commented to somebody yesterday about one of these. So all of a sudden you're seeing these one-pagers that have a zillion different criteria on them for a specific pathophysiology, as an example, ARDS. So I saw one yesterday on LinkedIn that was published, and basically it was clearly an AI generated recommendation, because it had things on it like SIMV, good for weaning. APRV, great for severe ARDS. And so I commented on this particular thing and basically said, you have to really be careful about how you interpret the literature in the data, especially if you're going to prognosticate or if you're going to pontificate on these things and put together an informational and send it out to thousands of people. Then you really need to make sure that, and that's why I like to have this panel discussion, right? Because we're not saying, there's not one of us that's saying this is the right thing to do. We're trying to get at a reasonably appropriate answer to a question based on our knowledge of the literature and also our experience. And so to go on to AI, you can, I think that AI is certainly has potential to be useful in some things, but I think to do a general search for ARDS and then take whatever AI gives you and then build some sort of a teaching tool from that is a big mistake. And because it really doesn't get into the weeds or the detail about the topic that you're really trying to elaborate on. So I'm not a big fan. I don't use AI in that way. I do old-fashioned literature reviews and call up Tom or call up Troy or call up Andy, and and we talk about things and come up with an answer. But I don't like the way that it's so easy to just to put something together. It really looks like it was well thought out, right? It's got a lot of detail in it, and man, it really looks like. And I'm thinking, well, how does this one person have all this time to put a new one of these, publish a new one of these every day on a different topic? And it's clear that it's been done by with AI, and it's also clear that some of the things that are being put out there are not true and not accurate.
Yeah, I think AI is only as useful as the person's knowledge of using it. So, for example, if you were to generate something with AI, you could guide it to make sure it's saying the right thing and evidence based. Like, so I don't think the problem is much with AI. It's that using it and not having the base knowledge to critique what it's suggesting. Like, for example, suggesting that SIMV is a great weaning mode in adults when it was proven in the 90s not to be a great weaning mode. Clearly, if you don't have the knowledge, you're just going to look at this thing and go, great, I'm going to put this on the internet. And so it's important that, you know, I mean, I use AI daily in my programming, but I also have to understand it. I used AI to build the simulator, right? But I had to know exactly what to tell it. And when it was doing something that didn't look right, I had to be able to explain to it why it wasn't right, give it the proper equations. So yeah, you have to understand the content in order to use AI effectively. Otherwise, you're just spitting out garbage because AI is going to mess it up. You're right. It's going to look at the whole of the internet. It doesn't just look at good published studies. It looks at blog posts. It looks at
Other AI generated information.
Yeah, exactly. It looks at everything. So I agree.
Good
Andy,
question.
Troy, you guys got anything else to add? This is a good one. I personally would say no. In the ProSeva study, they did not include any sort of PEEP titration algorithm after putting the patients in the prone positioning. In fact, the easiest way, or I would say probably the most effective way to recruit a lung is to simply put them in a different position because your pleural pressures change. But I'm going to share a post or a paper here by Bhushan Katira. This was an animal model, but it demonstrates what happens when you place a patient in the prone positioning. So in this supine position, I'll just sort of explain what we're looking at here. The upside down triangles here is respiratory system compliance. Okay, so you can see this red line represents the...
You're not sharing, Tom. There we go.
Oh yeah, that's right. There we go. Thanks for pushing that up there.
You're welcome.
So the red line here shows the highest compliance. So these upside down triangles is respiratory system compliance, and this red line is the most compliant area for the respiratory system compliance. But then the white circles are the dependent regions of the lung. Okay, and you can see the dependent region actually closely reflects what the optimal compliance is here in the entire respiratory system. But then when you look at the non-dependent regions in the supine position, you can see that the optimal compliance is way down here. And these are PEEP levels down here. So an optimal compliance for your dorsal lung region is around 15, and that is reflected in the respiratory system compliance. But it's actually results in worse compliance in the non-dependent region, which makes sense because this is the area that's already open, right? So PEEP might open the lung, but it's going to over-distend the region in the front of the lungs. And the best compliance for that is down around 8. But look what happens when you prone. Again, this is an animal study, but in the prone positioning, how it homogenizes. So the optimal compliance is around here, and the optimal compliance in both regions are essentially within 2 centimeters of water of each other. So just by putting the patient in a different position, you sort of homogenize the regions that benefit from the level you're on. So if you wanted to do PEEP titration, sure, but there's some studies that have shown some patients need like some EIT guided studies showing some need higher PEEP, some need lower PEEP, but essentially keeping them there, you're going to homogenize the regions of the lung that are being ventilated. The average PEEP that was used in the ProSeva study was around 10 centimeters of water. And they didn't have an algorithm for adjusting their ventilation strategy once they put the patients prone. And it, to date, is the largest reduction in mortality we've seen in a randomized controlled trial for ARDS patients. So I wouldn't stress out too much about titrating your PEEP, provided you have a reasonable amount of PEEP. I mean, again, in the average in the study was 10. If you have a patient on PEEP of 5, maybe they could benefit by higher PEEP. in both the supine and the prone position. But in terms of like manipulating your settings, just making sure you have, decent tidal volume, obviously, for ventilation. If you do lose tidal volume when you put them in the prone position, you may need to adjust it, knowing that it may be safer to do that because your chest wall does become stiffer because your spine is not very compliant. Your rib cage is very compliant compared to your spine.
Which is why proning works, right?
Yeah. Yeah, it forces the volume into the larger regions of the lung and towards the diaphragm. So yeah, there's all these physiological benefits. But yeah, I just wanted to share that. I saw this question earlier, so I got that study ready on another tab so that we could so I could show you that.
Well, we're past our hour by a little bit here. I think that we should wrap this up. Tom, is there any way we can respond to these questions after the fact? Some of the ones that have been answered.
I think if we come back into the studio after, I think they are there. I mean, really, there's just one more question if we want to just target that and then call it a day.
Let's do that.
There's just this one here. I think the rest are just sort of comments on what we were saying. So what treatment considerations for a C3 injury to maximize respiratory strength for a patient off the vent during the day? Any insight on functional electrical stimulation? Not my area of specialty, so I'm just going to keep
I don't know much about functional electrical stimulation. I've taken care of many high C-spine injured patients, and as a matter of fact, this would be a good time to mention. We have a podcast, and
I was just going to say maybe we should divert this to our discussion with Dr. Jeff Singh.
Yeah, we're going to have an episode with Dr. Jeff Singh, who is an expert in all things spinal injuries, and we are going to talk to him about spinal cord injury, SCI protocols, and what modes of ventilation to use. Should you use lower PEEP, higher tidal volumes, which I think is the issue. And so I would refer you to that, to be honest with you. We'll ask him about the functional electrical stimulation during our podcast, now that you brought that up. So I think unless somebody has something to add to this, we'll just kind of leave it there. I would like to advertise our podcast. It's called The Gas Exchange, and we are publishing one episode every 2 weeks on Mondays. And can you put the link to follow our podcast up there, Thomas?
Which link on YouTube, or?
Let's do YouTube. Yeah, I can do it. You can do it faster, but I can do it.
It's a race.
Oh.
Well, that's the introduction. So let me go to the channel and then let me share. Oh, I'm subscribed.
Boom. Done.
Oh, okay. You did. You beat me. There you go.
So anyway, sign up and watch. It's also getting pushed out to Apple and to Spotify, etc., and Podbean and all things. But that's a good way to see the videos. So with that, I'll thank the panelists, and I'll thank everybody who signed on and asked questions. I wasn't sure how well this was going to go, but we could probably go on for.
I feel like we could do this more often, and actually, it's kind of. I'm sure the people. I mean, people signing up for it might not think it might be useful, but I think the people that were here enjoyed themselves. So
yeah,
maybe,
we did.
The next time. And the next time we announce an open mic, maybe the people that attended could say, "Hey, it was actually good. You guys should register."
Yeah, let's do this more. Let's do this open mic thing more often. All right, guys, thank you so much for everything to the panelists, and thanks for the audience. And please go to our website and recommend topics. If you like the open mic thing, tell other people about it so we can get more participation, and we'll do it more often. All right. Thank you, guys.
Thank you.